Welcome, everyone, to Developing Connections, a podcast that brings together science, story, and systems to explore how early experiences shape lifelong health. I'm your host, Brandy McEwen. Today's episode is close to my heart and critical to our communities: the impact of maternal mental health on infant development. Over the next 20 to 30 minutes, we'll move through three vital perspectives: the science of early childhood development and maternal mental health, the lived experience of parenting through mental health challenges, and the policy landscape here in Florida that either supports or hinders families and professionals. Our goal is to connect real world experiences to the systems and evidence that can actually improve outcomes for parents and babies. This podcast features a multidisciplinary panel, including a maternal mental health expert, a developmental scientist, and a parent with lived experience, providing a comprehensive view on maternal mental health's influence on infant development. Each speaker brings unique perspectives, setting the stage for a holistic discussion combining personal narrative, policy analysis, and scientific evidence. First, let me introduce our speakers. Cuzo is our developmental scientist who will walk us through the biological and psychological mechanisms linking maternal mental health to infant development. Later on, we'll hear from Brandy Barnes, who will share her personal journey as a parent navigating postpartum mental health, a powerful reminder that behind every statistic is a human story. And I'll be bridging these insights with a look at Florida's policies, practices, and persistent gaps. Before we dive in, I want to ground us in why this topic matters. As the Harvard Center on the Developing Child reminds us, early childhood is a period of unparalleled brain plasticity, a time when positive interactions build sturdy brain architecture, while adversity, including a caregiver's untreated mental health struggles, can trigger toxic stress that disrupts development. That's not just a theory. It's evidence from decades of developmental science, which we'll hear more about from Lexis. So let's begin with the science. Lexis, take it away.
Thank you, Brandy. Now allow me to guide us through the science behind early childhood development and how maternal mental health affects infant brain development. In the domain of early childhood development, the research from the Harvard Center on the Developing Child shows that the first 5 years of life are a major period for brain development. From birth to 6 months, the development of a baby's brain is quickly forming connections, starting the foundation for learning and emotional development. Then, between 6 and 12 months, early interaction, such as with family and caregivers, begin to mold the brain architecture in significant ways. Between 24 and 36 months, those already formed connections in the brain improve to then support skills such as social interaction, emotional regulation, and thinking. Finally, when children reach 5 years old, the brain achieves near peak connectivity. The timeline illustrates how vulnerable early development is and how all experiences throughout this time, especially maternal mental health, can have a continuing impact. The research in neurodevelopment and stress biology conveys a compelling correlation between infant brain development and maternal mental health. While maternal mental health is positive, healthy brain connectivity is supported in parts that are responsible for cognitive development and emotional control. This aids in infants' development in stability, learning skills, and the capability to manage stress. But when there is a negative impact on maternal mental health with ailments like depression or chronic stress, the infant's brain development is affected in the areas connected to managing emotions. An essential factor is cortisol, which is known as the body's central stress hormone. When cortisol levels are high, particularly during pregnancy, it can disturb fetal brain development and increase the risk for mental health challenges in the future, such as anxiety. This emphasizes how tightly connected a mother's emotional well being is to her child's outcome in their development. As it is explained in the research done by Andrew Garner and Jack Shonkoff, those findings are closely correlated to the ideas of resilience and adversity, such as maternal health issues, which can cause toxic stress responses in children. The occurrence of toxic stress is when children are constantly experiencing continued stress without the necessary supportive relationships to buffer the negative impact it has on brain development and their overall health. Yet, resilience can play a significant role with supportive caregiving, early intervention, and environments that are nurturing, aid in defending against the effects of adversity, and support healthy development. These protective factors can lead to the improvement of long term effects like physical, cognitive, and emotional development throughout life.
Thank you, Lexis. You've laid out the why. When a parent's mental health is compromised, the very interactions that wire an infant's brain for resilience can become fragmented, leading to long term risks for cognitive, emotional, and even physical health. It's a powerful call to action, one that brings us to the next critical question: what is Florida doing about it? Let's start with the positives. Florida has a statewide screening mandate through the Healthy Start Services program. According to the Florida Department of Health, Healthy Start participants are screened face to face using the Edinburgh Postnatal Depression Scale once by 28 weeks gestation, then again at 1 month and 2 months postpartum. That's a structured, evidence based approach. Birth centers are also required under Florida law to include mental health screening in postpartum evaluations. And in 2024, the state launched an electronic prenatal screening tool that lets providers send screening links to patients before their first visit, a step toward reducing barriers to early identification. Another positive: Florida extended postpartum Medicaid coverage to 12 months after birth or pregnancy loss. That's huge for continuity of care, especially for low income families. The Florida Hospital Association issued a statewide call to action during Maternal Mental Health Week, hosting webinars for over 80 professionals on screening, referral, and suicide prevention. So there are pieces of a supportive system in place, but, and this is a big but, these pieces don't add up to a comprehensive, equitable safety net. According to the 2024 Policy Center for Maternal Mental Health report card, Florida earned an F grade for screening and reimbursement. Why? Because unlike some states, Florida has no universal mandate requiring all providers or insurers to cover routine prenatal or postpartum depression screenings. Commercial insurance and Medicaid plans here are not required to collect or report on these measures, and claims for postpartum depression screening are submitted at rates under 1%. That means most mothers are never screened at all, or if they are, there's no guarantee their insurance will even cover it. This leads directly to what researchers call the evidence to implementation gap. We have strong science, like the work of Boyce, Sokolowski, and Robinson on the biology of social adversity, or Shonkoff and colleagues on toxic stress, showing that early intervention can alter developmental trajectories. Yet in Florida, we struggle to get those interventions to the families who need them most. The gap shows up in geographic disparities. Screening and services might be available in urban hubs like Miami or Orlando, but in rural counties like Liberty and Hardy, families often face fewer providers, longer travel times, and fewer referral networks. A mom in a rural community might get screened through Healthy Start, but if the nearest therapist is 50 miles away and doesn't accept our insurance, what then? Funding instability magnifies these inequities. Programs depend on shifting legislative allocations and grant cycles, creating what one report called inconsistent implementation and uneven continuity of services across counties. Providers say they are constantly adapting to new rules, chasing new funding streams, and struggling to maintain staff training, all of which fragments care and burns out the workforce. That brings me to the professional practice dimension and how these policy gaps translate into practice challenges. First, inadequate provider training. Many OBGYNs, pediatricians, and even mental health professionals receive minimal education on perinatal mental health. They may not know how to use screening tools effectively, how to discuss results sensitively, or where to refer patients for specialized care. Second, limited family engagement structures. Even when services exist, they're often designed for the system's convenience, not the family's reality. A mom with a newborn can't easily attend weekly therapy sessions during business hours, especially if she has other children or lacks transportation. We need more flexible, family centered models like telehealth, home visiting, peer support groups that meet the families where they are. Third, insufficient or fragmented funding streams. This creates what the Harvard Center on the Developing Child calls suboptimal integration of interventions that have been proven effective. Programs that work, like home visiting or peer support, often operate on short term grants or pilot funding. When the money runs out, so does the service. This isn't just frustrating for families, it erodes trust in the system. A mother finally opens up, gets connected to a support group, and then 6 months later, that group disappears because the grant ended. What message does that send? So, where does this leave us as professionals working in Florida? We have strong scientific evidence from our course materials like Garner and Saul's work on developmental thinking to Boyce's research on the biology of social adversity that tells us that early intervention matters. We have policy frameworks that acknowledge the problem, but we have implementation gaps that undermine our ability to act on that knowledge. The reality is that many providers feel caught between what they know is right and what the system allows. You might screen a mother, identify depression, but then hit a wall. No nearby therapist taking new patients, no transportation assistance, no childcare during appointments, no insurance coverage for the specific treatment she needs. These structural barriers don't just hinder practice, they can make providers feel powerless, which contributes to burnout. But I don't want to end this segment on a note of frustration because there are also signs of hope. Some Florida counties are piloting integrated care models where mental health specialists co-locate in OBGYN and pediatric offices. Telehealth has expanded access in rural areas, and advocacy groups are pushing for more consistent funding and universal screening mandates. The key, as our course reference from the Harvard Center emphasizes, closing the gap between what we know and what we do. That requires coordinated workforce supports, practical engagement approaches for families, and sustainable financing that enables programs to deliver science aligned services. Now, let's hear from someone who's experienced this system from the inside. Brandy Barnes, thank you for joining us and for your courage in sharing your story. Brandy, take us through your lived experience.
Hi, Brandy. Thank you so much for having me. My name is Brandy Barnes, and I'm a mother of one. As a mother, maternal mental health isn't just something that I've learned about, it's something I'm currently living through. I wanted to start off with a personal experience since I am 6 months postpartum. There was a day, it wasn't long after my baby was born, when I was sitting on the floor holding him while he cried. I remember feeling overwhelmed and was emotionally exhausted. I was going through the motions, but inside I felt like I was failing. It wasn't because I didn't love my child, but it was because I just didn't feel like myself. Looking back, I can see that I was experiencing maternal mental health challenges that so many mothers face. In fact, according to the CDC, about 1 in 5 women experience postpartum depression or anxiety. In that moment, I didn't know that there was anything to it, I just knew it was super hard. What I've learned since is that these experiences don't just affect mothers, They shape infant development in powerful ways. Infants rely on consistent, responsive caregiving to build secure attachments, which are critical for brain development and emotional regulation. When a mother is struggling with depression or anxiety, those interactions can become disrupted. This is not out of neglect, but because the mother is carrying so much internally. I saw that in my own experience. There were times when I struggled to respond as quickly or as calmly as I wanted to. Research shows that maternal psychological distress can be associated with things like increased infant irritability, sleep challenges, and later developmental concerns. But this is where policy and practices play such an important role. One of the biggest barriers I faced was access to support. Finding affordable and timely care was not easy. Screening for postpartum mental health often felt brief or like a checkbox without meaningful follow up. I literally remember being handed a piece of paper and it said, "Do you experience any of these symptoms?" And that was it. And we didn't really discuss anything during the initial doctor's appointment. Plus, the stigma around needing postpartum help keeps many women from asking for it. It was always, "Oh, how's the baby?" and not, "How are you doing really?" Yet we know that early identification and intervention can significantly improve outcomes for both mothers and infants. Paid parental leave is another major factor. The pressure to return to work or bounce back too soon adds stress during an already vulnerable time. Studies show that longer maternity leave is linked to better maternal mental health and healthier infant development. I personally was only granted 4 weeks of paid parental leave. If I had PTO saved up, I could take that. But in the event I was unable to return to work after my leave, I would be forced to monetarily pay back all of it. They do give you federally 12 weeks of unpaid family leave, but the stress of not being able to pay your bills during unpaid leave is crazy. The important bonding time between mother and child should not have these added stressors. Childcare access also matters. When families don't have reliable, affordable options, it affects emotional well being and the overall environment the infant is growing up in. From my lived perspective, what would have made the biggest difference is a more connected system of care. That includes routine and ongoing mental health screenings, access to affordable therapy, community based support groups, and policies that recognize caregiving as essential and not optional. We also need to talk about stigma. For a long time, I didn't speak openly about how I was feeling because I was afraid of being judged, and I know that I'm not alone in that. Creating spaces where mothers can be honest and supported without fear is critical. Because when we support maternal mental health, we're not just helping mothers, we're directly supporting infant development. When a mother has the resources, support, and space to heal and thrive, her ability to connect, respond, and nurture her child is strengthened. Those early interactions shape everything from emotional security to long term health. So, this important conversation isn't just about maternal mental health, it's about the foundation we're building for our children. Thank you so much for having me.
Thank you, Brandy, for sharing your story. It shows what the policy reports can't capture: the emotional weight of navigating a fragmented system while trying to care for yourself and your newborn. It's a reminder that behind every screening statistic, every funding gap, there's a real family trying to find their way. Your experience also highlights something critical. Relationships matter. Whether it's the compassionate nurse who noticed you struggle or the support group that finally made you feel understood, human connection is often the bridge between identifying a problem and accessing help. This aligns with what we know from the developmental science. Responsive, attuned relationships buffer stress and promote resilience for both parent and child. That brings us back to the science of what works. Lexis, based on the evidence and Brandy's experience, What strategy should we be prioritizing to support maternal mental health and infant development?
In support of both infant development and maternal mental health, research and the lived experiences shared by Brandy, there are many evidence based strategies for practice. Firstly, supporting responsive and stable caregiving is important because relationships that are consistent and nurturing assist in lessening the effects of toxic stress and promote emotional security. With programs like home visitation, it lets professionals who are trained to help families by enhancing parenting skills and the outcome of the child. There are also parent education programs that provide caregivers with the abilities and intelligence to better support the healthy development of children. It is especially important to participate in early screening because it is critical in identifying the developmental risks and mental health concerns early for well timed intervention. There are also targeted interventions that can focus on any specific needs, but responsive caregiving remains the most essential protective factor against stress. These strategies are supported by W. Thomas Boyce and Jack Shonkoff by illustrating that lessening stress and improving caregiver interactions can lead to enhanced developmental results for children. To add to these strategies, there are practical steps that can be put into action to better support the families. This includes routine mental health screening during the prenatal and postnatal visits, which can aid in identifying any worries early on. Enhancing provider training, primarily in trauma informed and culturally open care, can even improve support for mothers. Advocating for policies is an important step since it aids in bettering access to both mental health support and maternal care services. Lastly, encouraging families with support networks and education can reinforce resilience and establish secure environments for children. Even though the research plainly displays what works, there is typically a gap between the information from the research and the real world practice. To close this gap, it is essential to utilize data informed decision making so programs can change and improve based on real outcomes. Supporting cooperation between community organizations, researchers, and healthcare providers can additionally enhance how services are provided. Participating in the development of the workforce safeguards that professionals are accurately trained to put into action evidence based practices. Furthermore, applying culturally sensitive and accessible interventions aids in ensuring that assistance gets to diverse communities effectively. Through linking science to real world applications, we can properly support both infants and mothers. Overall, it is clear from the research that maternal mental health plays a key part in molding the development of infants from the very start.
Thank you, Lexis, for those practical evidence based recommendations. You have connected the dots between science, lived experience, and policy action. As we wrap up today's conversation, I want to return to the core message. Maternal mental health isn't a sidebar issue, it's foundational to infant development and lifelong health. When we support a mother's well being, we're not just helping her, we're investing in her child's brain architecture, emotional regulation, and future potential. The science from Shonkoff shows us that early adversity, including parental mental health struggles, can become biologically embedded through toxic stress responses. But the same research tells us that responsive caregiving and supportive interventions can mitigate those effects. It's not about blaming or shaming, it's about building systems that recognize this biological reality and act accordingly. For a Florida context, here's what I hope stays with you. Screening must be universal. The current approach leaves too many mothers unseen. Every prenatal and postpartum visit should include mental health screening, with insurance coverage guaranteed. Access must be equitable. Rural and underserved communities need telehealth infrastructure, mobile services, and transportation support to bridge geographic gaps. Funding must be stable and sustainable. Programs that work shouldn't live grant to grant. We need multi-year funding streams that allow for planning, staffing, and meaningful evaluation. Workforce development is non-negotiable. All providers who touch families during the perinatal period, OBGYNs, pediatricians, nurses, home visitors, need training in perinatal mental health identification, response, and referral. Family voice must guide design. As Brandy's story showed, services work when they're designed with the real family needs in mind. For those wanting to learn more, I encourage you to explore the references from our course materials. Boyce, Sokolowski, and Robinson's work on the biology of social adversity, Garner and Saul's developmental approach to lifelong health, the Harvard Center on the Developing Child's resources on early adversity and toxic stress, Shonkoff, Slopin, and Williams' research on racism and early childhood adversity. You can also visit the Policy Center for Maternal Mental Health's 2024 Florida Report Card for current policy analysis and the Florida Department of Health's Healthy Start website for local resources. Remember, supporting maternal mental health isn't just healthcare, it's early childhood development policy and action. When we get this right, we're building stronger foundations for our children, our communities, and our collective future. This episode was produced as part of a multidisciplinary project exploring how maternal mental health shapes infant development. My sincere thanks to Lexis Cuzo for the science, Brandy Barnes for the story, and to you, our listeners, for joining this critical conversation. Until next time, I'm Brandy McEwen. Thank you for listening to Developing Connections.